Hello class, good day. It's me again, Ma'am Christine Orhena, and today we will be learning about the concepts of pulse and pulse assessment. Our lesson for today can be found in the Fundamentals of Nursing book by Potter and Perry, 10th edition, on pages 497 to 500. So let's begin. Before we talk about the pulse and its assessment, let us review again the flow of blood in our heart. So what happens? Where does the blood go in our heart? So one, the oxygenated blood enters the right atrium through the superior and inferior vena cava. The blood enters the right ventricle through the tricuspid valve and exits through the right ventricle through the pulmonary valve and enters the pulmonary artery. So the left and right pulmonary arteries send blood to the lungs where gas exchange happens or occurs. Then oxygenated blood returns to the heart via the pulmonary veins and enters the left atrium. Blood enters the left ventricle through the mitral valve, and the blood exits to the left ventricle through the aortic semilunar valve to enter the aorta. And the aorta is the one that distributes the blood to the body. So we talk a little about the blood flow as it goes in and out of the heart, as it will help us understand more when we talk about the pulse and its assessment. So when we talk about the pulse, so what is a pulse? The pulse is the palpable bounding of blood flow in a peripheral artery. Blood flows through the body in a continuous circuit. The pulse is an indirect indicator of the circulatory status of a patient. So now we talk about the physiology and the regulation of the pulse. Electrical impulses originating from the sinoatrial node travel through heart muscles to stimulate cardiac contraction. Approximately 60 to 70 milliliters of blood enters the aorta with each ventricular contraction, or what we call as the stroke volume. With each stroke volume ejection, the walls of the aorta distends, creating a pulse wave that travels rapidly towards the distal ends of the arteries. The pulse wave moves 15 times faster through the aorta and 100 times faster through the small arteries than the ejected volume of blood. When a pulse wave reaches a peripheral artery, you can feel it by palpating the artery lightly against underlying bone or muscle. So the number of pulsing sensations occurring in a minute is the pulse rate. The volume of blood pumped by the heart during 1 minute is the cardiac output, the product of heart rate and the stroke volume of the ventricle. In an adult, the heart normally pumps 5 liters of blood per minute. A change in heart rate or stroke volume does not always change the output of the heart or the amount of the blood in the arteries. For example, if a person's heart rate is 70 beats per minute and the stroke volume is 70 milliliters, so the cardiac output is 4.9 liters per minute. If the heart rate drops to 60 beats per minute and the stroke volume rises to 85 milliliters, then the cardiac output increases to 5.1 liters. So again, the cardiac output is equivalent to the stroke volume times the heart rate. Mechanical, neural, and chemical factors regulate the strength of ventricular contraction and its stroke volume. But when these factors are unable to alter the stroke volume, a change in heart rate causes a change in cardiac output, which affects the blood pressure. As heart rate increases, there is less time for the ventricular chambers of the heart to fill, and as heart rate increases without a change in the stroke volume, the BP decreases. As heart rate slows, filling time is increased and blood pressure increases. The inability of the blood pressure to respond to increases or decreases in heart rate indicates a possible health problem. We need to report this to the healthcare provider. An abnormally slow, rapid, or irregular pulse alters cardiac output. So we need to assess the ability of the heart to meet the demands of the body tissue for nutrients by palpating a peripheral pulse or using a stethoscope to listen to heart sounds, or what we call as the apical rate. So now let us talk about the factors affecting the pulse rate or influence pulse rate. The number one is age. So as age increases, the pulse rate gradually decreases. So it is normal for an infant to have a pulse rate or a heart rate of 150 or 159, as the heart rate range for an infant is 120 to 160. And it is abnormal for an adult to have 160 beats per minute pulse rate because it is above the normal range of the heart rate. So the other factors influencing pulse rate is we have the exercise. So a short-term exercise can increase your pulse rate, while a long-term exercise decreases the pulse rate. So if you have been exercising long-term, then your heart muscles are strengthened, resulting in a lower than normal rate at rest and a quicker return to resting rate after exercise. Another factor would be temperature. Fever and heat can increase your pulse rate, while hypothermia can decrease your pulse rate. Emotions as well can influence pulse rate. Sympathetic stimulation, which is caused by acute pain or any stressful event, can increase your pulse rate, while parasympathetic stimulation decreases your heart rate. Medications as well. The positive chronotropic drugs, such as epinephrine, can cause an increase in pulse rate, while the negative chronotropic drugs, such as digitalis, beta-adrenergics, and calcium channel blockers, can decrease your pulse rate. Hemorrhage, also caused by the sympathetic stimulation, is increased by the loss of blood, and it increases your pulse rate. The other two factors that influence pulse rate is postural changes. Standing or sitting can increase pulse rate, while lying down can decrease your heart rate. Pulmonary conditions, diseases causing poor oxygenation, such as asthma or chronic obstructive pulmonary disease, can cause an increase in pulse rate. So let us now talk about the pulse sites. So there are 10 pulse sites in our body where we can palpate or auscultate to check or take the pulse rate. So I want you to try and locate them yourselves, as some of these sites are hard to palpate and you need a lot of practice to feel and locate them. If you're unable to locate it yourself, try to locate it in another person, as pulse strength can differ from one person to another. So the first pulse site I want you to check is your temporal pulse. So this site is superior, above, and lateral away from the midline of the eye. It is used when radial pulse is not accessible. It is also used to assess the pulse in children. The next site would be your carotid. It is located at the side of the neck below the lobe of the ear, where the carotid artery runs between the trachea and the sternocleidomastoid muscle. It is used for infants and when there is a cardiac arrest to assess the circulation to the brain. It is easily accessible site used during the physiological shock or again cardiac arrest and when other sites are not palpable. The next site would be your apical site. It is located at the apex of the heart. So for the adult, it is located on the left side of the chest under the 4th, 5th, or 6th intercostal space. While the child, 7 to 9 years old, the apical pulse is located between the 4th and the 5th intercostal space. The child below 4 years old, it is located in the left of the mid-clavicular line. And a child between 4 to 6 years old, it is at the mid-clavicular line. So the uses. It is routinely used for infants and children up to 3 years old, used to determine discrepancies with radial pulse, and is used in conjunction with some medications. So this pulse site, you need a stethoscope to check the pulse rate. So the fourth site would be your brachial site. It is located in the groove between biceps and tricep muscles at the antecubital fossa. It is used to measure blood pressure, and it is also used during cardiac arrest in infants. The fifth site would be a radial site, where the radial artery runs along the radial bone on the thumb side of the inner aspect of the wrist. It is readily accessible and routinely used. The sixth site would be your femoral site, where the femoral artery passes alongside the inguinal ligament. It is favorably used during cardiac arrest or shock in infants and children, and to determine circulation of blood to the leg. The next site would be your popliteal, where the popliteal artery passes behind the knee. This point is difficult to find, but it can be palpated if the client flexes the knee slightly. It is used to determine the circulation to lower leg and determine leg blood pressure. The next site would be your posterior tibial. It is on the medial surface of the ankle, where the posterior tibial artery passes behind the medial malleolus. It is used to determine circulation to the foot. The next site would be your pedal or your dorsalis pedis. It can be palpated by feeling the dorsum of the foot on an imaginary line drawn from the middle of the ankle to the space between the big and the second toe. It is used to determine circulation to the foot. And the last pulse site would be your ulnar site. It is located in the ulnar or little finger side of the forearm at the wrist. This site is used to assess the status of circulation to hand, and it's also used when performing Allen's test. So we will talk now about assessment of pulse. You can assess any artery for pulse rate, but you typically use the radial artery because it is easy to palpate. When a patient's condition suddenly worsens, the carotid site is recommended for quickly finding and assessing the pulse. The heart continues delivering blood through the carotid artery to the brain as long as possible. When cardiac output declines significantly, peripheral pulses weaken and are difficult to palpate. The radial and apical locations are the most common sites for pulse rate assessment. If the radial pulse is abnormal or intermittent resulting from dysrhythmias, or if it is inaccessible because of a dressing or cast, assess the apical pulse. When a patient takes medications that affects the heart rate, the apical pulse provides a more accurate assessment of heart function. The brachial or apical pulse is the best site for assessing an infant's or a young child's pulse because the other peripheral pulses are deep and difficult to palpate accurately. So pulse is commonly assessed by palpation or auscultation. We use the middle three fingertips, except on the apex of the heart when we check the apical pulse because we use the stethoscope, and the pads on the most distal aspect of the fingers, so because they are the most sensitive areas for detecting a pulse. So with excessive pressure, one can obliterate a pulse, whereas too little pressure, one may not be able to detect it. Let us now look into the character of a pulse. Assessment of the radial pulse includes measuring the rate, rhythm, strength, and equality. But when auscultating an apical pulse, we only assess for the rate and rhythm. We do not need to check for equality as there's only one heart. So let's talk about the rate. Before measuring a pulse, review the patient's baseline rate for comparison. When assessing the pulse, consider the variety of factors influencing the pulse rate, as we've discussed earlier. A single factor or combination of these factors often causes significant changes. So if you detect an abnormal rate while palpating a peripheral pulse, the next step is to assess the apical rate. The apical rate requires auscultation of heart sounds, which provides a more accurate assessment of cardiac contraction. So we assess the apical rate by listening to the heart sounds. Identify the first and the second heart sound. So at normal slow rate, the first heart sound is low-pitched and dull, sounding like a lub. The second heart sound is higher pitched and shorter, creating the sound dub. So count each set of lub-dub as one heartbeat. Using the diaphragm or bell of the stethoscope, count the number of lub-dubs occurring in a minute. Peripheral and apical pulse rates assessment often reveals variations in heart rate. Two common abnormalities in pulse rates are tachycardia and bradycardia. Tachycardia is an abnormal elevated heart rate above 100 beats per minute in adults, and bradycardia is a slow rate below 60 beats per minute in adults. So again, tachycardia is excessively fast heart rate, while bradycardia is slower than normal heart rate. An inefficient contraction of the heart that fails to transmit a pulse wave to the peripheral pulse sites creates a pulse deficit. To assess a pulse deficit, you and a colleague assess radial and apical rates simultaneously and then compare rates. The difference between the apical and the radial pulse rates is the pulse deficit. For example, an apical rate of 92 with a radial rate of 78 beats per minute leaves a pulse deficit of 14 beats per minute. So pulse deficits are often associated with abnormal rhythms. The next character of the pulse is the pulse rhythm. Normally, a regular interval occurs between each pulse or heartbeat. An interval interrupted by an early or late beat or a missed beat indicates an abnormal rhythm or dysrhythmia. A dysrhythmia threatens the ability of the heart to provide adequate cardiac output, particularly if it occurs repetitively. You identify a dysrhythmia by palpating an interruption in successive pulse waves or auscultating an interruption between heart sounds. If a dysrhythmia is present, assess the regularity of the occurrence and auscultate the apical pulse. To document a dysrhythmia, the healthcare provider often orders an electrocardiogram or the ECG. An ECG records the electrical activity of the heart for a 12-second interval. This test requires placement of electrodes across a patient's chest, followed by recording the heart rhythm. Children often have sinus dysrhythmia, which is an irregular heartbeat that speeds up with inspiration and slows with expiration. This is a normal finding that you can verify by having the child hold his or her breath. The heart rate usually becomes regular. The next character would be pulse volume or pulse strength or amplitude. The strength or amplitude of a pulse reflects the volume of blood ejected against the arterial wall with each heart contraction, and the condition of the arterial vascular system leading to the pulse site. Normally, the pulse strength remains the same with each heartbeat. So you document the pulse strength as 0 if there's absent pulse, meaning there's none felt, 1 plus if it's thready pulse, it's difficult to feel, not palpable when only slight pressure is applied. You put 2 plus when there's a weak pulse, stronger than a thready pulse but not palpable when light pressure is applied. 3 plus, it is a normal pulse, easily felt but not palpable when moderate pressure is applied. And 4 plus, when there's a bounding pulse, when it feels full and spring-like even under moderate pressure. The last character of a pulse is equality. We assess radial pulses on both sides of the peripheral vascular system, comparing the characteristics of each pulse. A pulse in one extremity is sometimes unequal in strength or absent in many disease states. Assess all symmetrical pulses simultaneously except for the carotid pulse. Never measure the carotid pulses simultaneously because excessive pressure occludes blood supply to the brain. So we cannot end our discussion of the pulse and its assessment without getting to know our stethoscope. So the stethoscope is used when taking blood pressure using the brachial pulse, and when assessing the apical rate, we require a stethoscope. The 5 major parts of the stethoscopes are the earpieces, the binaurals, tubing, bell, chest piece, and the diaphragm chest piece. The plastic or rubber earpieces should fit snugly and comfortably in your ears. The binaurals should be angled and strong enough so the earpieces stay firmly in the ears without causing discomfort. To ensure the best reception of sound, the earpieces follow the contour of the ear canal pointing towards the face when the stethoscope is in place. The tubing is flexible and is 12 to 18 inches in length. Longer tubing decreases the transmission of sound waves. Thick-walled and moderately rigid tubing eliminates transmission of environmental noise and prevents the tubing from kinking, which distorts sound wave transmission. Stethoscopes have single or dual tubes. The chest piece consists of a bell and a diaphragm that you can rotate into position. The diaphragm or bell needs to be in proper position during use to hear sounds through the stethoscope. With the earpieces in your ears, tap lightly on the diaphragm to determine which side of the chest is functioning. The diaphragm is the circular, flat portion of the chest piece covered with a thin plastic disc. It transmits high-pitched sounds created by the high-velocity movement of air and blood. Auscultate bowel, lung, and heart sounds with the diaphragm. Always place the stethoscope directly on the skin because clothing obscures the sound. Position the diaphragm to make a tight seal and press firmly against the patient's skin. Do not use your thumb to hold the diaphragm in place because you may hear the pulse being transmitted through it. The bell is a bowl-shaped chest piece usually surrounded by a rubber ring. The ring avoids chilling patients with cold metal when it is placed on the skin. The bell transmits low-pitched sound created by low-velocity movement of blood. We auscultate the heart and the vascular sound with the bell. So we apply the bell lightly, resting the chest piece on the skin. Compressing the bell against the skin reduces low-pitched sound amplification and creates a diaphragm of skin. Some stethoscopes have one chest piece that combines features of a bell and diaphragm. When you use light pressure, the chest piece is a bell, and exerting more pressure converts the bell into a diaphragm. The stethoscope is a delicate instrument and requires proper care for optimal function. The earpiece should be removed regularly and cleaned of cerumen or earwax. The bell and diaphragm are cleaned of dust and lint and body oils. And clean the tubing with mild soap and water. We need to clean the bell and the diaphragm between patients with an antiseptic swab to remove microorganisms. And that ends our discussion of the concepts behind pulse taking. I encourage you all to jot down your questions, or if you need any clarifications, discuss it with your clinical instructor during your synchronous classes. So with that, I bid you all a good day, stay safe, and God bless.